vessel, then this will cover all types of aneurysms. Arteriomegaly is not an aneurysm by itself, but it's a diffuse dilatation and frequent elongation and tortuosity of the widened aorta by 5 millimeters, then we speak about aneurysm of this dilated part. What about the etiology? It is rare actually before the age of 35, but if it is present, then it is naturally in younger age groups with Marfan syndrome, Ehlers-Danlos syndrome, and Arteria magna syndrome. Instead, and actually in 2.2% of all deaths in men between 70 and 74 years is caused by aneurysm. 77 are due to abdominal aortic aneurysms, and this comprises 5% of all sudden deaths. This diagram will show the death from the aortic aneurysm as a percentage of all deaths for men's age. We notice that prevalence actually, than the general population we find in people suffering from hypertension, ischemic heart disease, peripheral vascular disease, and carotid artery disease. What about the etiology? Genetic predisposition is known. The prevalence in brothers and sons of aneurysm patients is as high as 50%. Medial disease, which is present in younger age groups, is caused by connective tissues of the following layers: intima, that's an epithelium, and subintima, which is a loose areolar tissue, then the media, which is a thick muscular tissue with elastic fibers, and the adventitia, which is a thick fibrous tissue, which gives the vessel its shapes, prevents it from overdistension, and gives its blood supply through the vasa vasorum. The four components of the media are smooth muscle, which provides the tone to the wall of the arteries and veins, and elastic fibers, and this determines the distensibility of the vessel. Collagen fibers give the strength to the media, and the mucopolysaccharides as part of the aging process. It's just a matter of how much. The proteolysis theory of aneurysms formation tells us that there might be deficiencies of collagen and elastin in the aortic wall, and there's increased circulation levels of collagenase or elastase. There might be also decreased protease inhibition. Male sex, advancing age, tobacco smoking, hypertension is some of the environmental influences which causes aortic disease leading to aortic aneurysms. Chronic obstructive airway disease as well, irrespective of the history of smoking, and occlusive arterial disease affecting coronary arteries, carotid, and limb arteries as well. Advanced age and tobacco smoking, this will certainly interact with the environmental influences. There's only in rare cases after massive trauma to the abdomen, a blow to the abdomen or to the aneurysmal site. Small aneurysms between 4 and large aneurysms, that means larger than 6 centimeters in diameter. In these people, there is not too much chance. Without surgery, they die within 3 years because the expansion rate is higher than in the smaller aneurysms. And these people who die within 3 years, they die because of rupture of these aneurysms. We classify the aneurysms into 2 major groups: the congenital aneurysms and the acquired aneurysms. Congenital aneurysms, which appear in Marfan syndrome, Ehlers-Danlos syndrome, in Arteria magna syndromes. We find them in radial artery aneurysm and perianeurysm in the circulus of Willis at the base of the brain. If we say congenital aneurysms, we don't mean that the aneurysm is present at birth. We mean only that there are genetic factors which lead to the formation of aneurysms later in life. Acquired aneurysms are those aneurysms which are acquired in life due to many factors. We classify them into false aneurysm and true aneurysm. And the difference is that in true aneurysms, we find in the aneurysmal sac all layers of the arterial or venous wall. So all layers of the vascular wall are present, intima, media, and adventitia. Sometimes, if we find only the adventitia, we might see it as a true as well. But false aneurysms, where the aneurysmal sac does not contain any layer or just part of the layer. According to the shape, we classify them into fusiform aneurysms, saccular aneurysms, fusiform saccular aneurysms, dissecting aneurysms, and arteriovenous fistulae. The fusiform aneurysm is called fusiform, is a symmetrical dilatation of the vascular wall. They are more seen in people with atherosclerotic disease in the abdominal aorta and mainly below the renal arteries. Because the atherosclerotic disease is a degenerative disease, there is a symmetrical dilatation of the wall. In saccular aneurysm, only eccentric dilatation, just part of the wall is dilated. And sometimes it is caused by atherosclerotic disease if there is an ulcer in the intima, which causes weakness of the media and then bulging of the artery. But you congenital. This is a diagram shows a fusiform aneurysm of the abdominal aorta below the renal arteries. Fusiform is symmetrical in shape, involving the whole infra-abdominal aorta, but also there is another aneurysm involving the left common iliac artery and the internal iliac artery. In this diagram, we see atherosclerotic disease of the aorta, iliac, and femoral arteries are involved. This comprises 10.9% of cases, type 3, 7.7, and this is the femoral and popliteal arteries. But here, in 81.93% of the cases, we found generalized ectasia of the abdominal aorta, iliac arteries, femoral arteries, and popliteal arteries as well. This here, a drawing here, which indicate the presence of atherosclerotic disease as basis and cause for this aneurysm. This is chest X-ray, which shows us the dilated ascending aorta, aortic arch, descent of living artery, and down involving also the upper part of the abdominal aorta after its entrance through the aortic hiatus. A CT scan of an aneurysm of the abdominal aorta, which shows the lumen here down through until the aorto-iliac bifurcation. And here's the arteriogram of this aneurysm. Here's an aneurysm involving only the ascending aorta and the aortic arch. And here's the angiogram showing the down to the aorto-iliac bifurcation. This is a CT scan of a ruptured abdominal aortic aneurysm, and here a CT scan of a confined rupture. The confined rupture means the aneurysm has ruptured, but it is confined by surrounding tissue, and because the abdominal aorta lies in the retroperitoneal space. If the peritoneum is intact, they usually are confined. But usually if the peritoneum ruptures, then the aneurysm cannot be confined anymore. Another CT scan of an atherosclerotic abdominal aneurysm, inflammatory abdominal aneurysm with thickening of the wall, and here of atherosclerotic aneurysm of the abdominal aorta with free lumen and intramural thrombus. Another CT scan of a patient with an inflammatory aneurysm. Here's an arteriogram of the abdominal aorta showing irregularities of the wall. It shows aneurysmal dilatation. We know that this patient has an aneurysm, but if we do just an arteriogram of these people without other methods to assess the condition, we cannot always decide upon the size of the aneurysm, because the aneurysm might be that size, like that, but this here is only the central canal. The rest of the aneurysm will be usually filled with debris, thrombus, and other material. So the dye will run only through the central canal. We just saw the irregularities, and here the tortuosity of the common iliac vessels as a sign of diffuse atherosclerotic disease as a basis of the condition. Here's an arteriogram showing a popliteal artery aneurysm here from a saccular type, and this aneurysm was produced actually in a patient with atherosclerotic disease. We can see here the branches of the popliteal artery. This is the posterior tibial artery, which is very narrow, and the lumen is not quite well. The anterior tibial artery with a better lumen. So the basis of this condition here is atherosclerotic disease. Here's the same patient, the MRI of this patient, which shows the dilated popliteal artery with intraluminal or mural thrombus. According to etiology, we classify them into atherosclerotic aneurysm, congenital aneurysm, traumatic, inflammatory, and infectious. Infectious, which we call also mycotic. Atherosclerotic aneurysms are the most common type of the aneurysms. And as I said, involves the abdominal aorta, mainly the infrarenal part of the abdominal aorta, causing fusiform aneurysms. Congenital aneurysms are caused by medial disease, which we discussed before. Traumatic aneurysm is caused by any trauma. It can be false aneurysm, can be dissecting aneurysm, saccular aneurysm. Any type of an aneurysm can arise from trauma. Inflammatory aneurysms, we actually talk about specific and non-specific inflammation. If we talk about specific inflammation, then we mean syphilis, for example, which affects the media. We know that the syphilis causes perivasculitis. The perivasculitis will attack the vasa vasorum as well. That leads to weakening of the wall. This, with deposition of gumata, will lead to the weakening of the whole wall, leading to the formation of aneurysms. These aneurysms usually appear in the thoracic aorta, in the descending thoracic aorta. Infectious has been called mycotic, and it is still called mycotic, but it does not mean it is fungus. It is bacterial infection. When it was discovered in the late 19th century, they thought it was due to fungus infection, but later on it has been found it is due to bacterial infection. They kept the name mycotic aneurysm in use. This here is an example of a mycotic aneurysm in the cubital vein in a patient who used to inject himself with drugs in the arm vein, so it's a drug abuser. Here we can say traumatic aneurysm of the aneurysm. This here is a mycotic aneurysm in a patient after subacute bacterial endocarditis. This patient has been treated with antibiotic, but the aneurysm remained. This is an arteriogram of a saccular aneurysm of the splenic artery found by Slovenia. People with known atherosclerotic disease who complain of chronic low backache must be seen as potential candidates for abdominal aneurysms. You have to exclude abdominal aneurysm before you think of other causes like discopathies or other spinal instability. The patient might complain of a pulsating mass in the epigastrium, or they might present with gastrointestinal or urological symptoms. Thromboembolic phenomena might appear, presenting with high output cardiac failure. Ureteric occlusion might appear in inflammatory aneurysms because the inflammatory process involves the retroperitoneal space. We call it the retroperitoneal fibrosis. This might involve the ureters causing hydronephrosis with all its symptoms. Duodenal obstruction might take place. Aortoduodenal fistula with bleeding into the duodenum causing either melena or people who develop acute rupture or confined rupture or leaking. If they are operated, 60% of these people will survive. People might go into a chronic condition with chronic rupture. This will last for a few months and people at the end will die. Investigations of aneurysms. Naturally, we have to examine the patient first. Abdominal examination in a supine position